Z effect. Okay. But just get the definition what it is, and then I'll let you know. So what is it? How will you define a Z effect? What it involves is lateral migration of the inferior screw. When we talk about the Z effect, it is the lateral migration of the inferior screw. That's how it goes. And we take it on from there. Obviously, with that, there can be a varus collapse, and there can be perforation of the femoral head by the superior screw. This is a secondary effects of the lateral migration. And what is a reverse Z? Is this what it is? It's just the upside down, so it becomes a reverse Z, which is involves a lateral migration. Again, we talk about the lateral migration, but it's a superior screw accompanied by the medial migration of the inferior. So this is the definition. The effect of this complication is a dubious privilege for the nail. The PFN is highly praised, but it's a dubious privilege for the double screw proximal locking PFN. It doesn't happen with any other system, of course, not even in the recon system, but it does happen with this nail. So what happens with the Z and the reverse Z? It's a migration in the opposite directions that you can see. But in practice, it may not be all the time it is opposite directions. And it may not be that both the screws are going to opposite direction. It may be just one screw going either laterally or medially, either the superior one, the inferior, whichever. It just could be one screw, and then it can either perforate or it can come out, whichever way that it goes out. Now, what is the reason behind it? Is it because of surgical problem? Is it because of the patient problem? Is it because of something else? Is the nail design, is that a problem, or something else? So what is the occurrence of the Z and the reverse Z? It has not been completely elucidated so far. Of course, we think about certain things. Now, such complications are obviously there during the fracture fixation if it is fixed in a varus position, if there is a severe medial combination, if there is going to be an inappropriate entry point which is far too lateral or through the fracture site of the intertrochanteric going to the GT, so the entry point is being wrong, or being the poor osteoporotic bone. So these are the various figures have been come forward to show that it can produce that effect, one of the effect. Now, can it be the other way around? What about the load transfer? It is a weight bearing. It's a weight bearing area. Even if you're going to be sleeping or doing a straight leg raising, it's going to be weight bearing on that leg, on the hip joint. So what is that load transfer there? That is the inferior lag screw migration component of the Z phenomenon that you can see was reported in the specimens as well. So some of them started doing the research on the specimens. And what does that say there? It's that very similar that the head compression strength, or the head compression which goes from the weight bearing, that were higher than the compression strengths of the neck. So the head compression is more than the neck, so it starts moving out. So that's the load transfer, which happens also, obviously, as you can see, it's classical in the weight bearing situation where that's what happens. So lab studies, again, favors in that sort of an area where that the femoral head had a higher compressive strength load going through than the femoral neck itself. And that can also simulate exactly the same way where there is a medial combination, cortical combination, and there is a prone to a varus collapse. So all these falling in the place where there is the strength of the power which is going through the compressive strength going on the head was more than the femoral neck. So the inferior lag screw migrates, as you've seen, that there are higher strengths which is going on the head than in the neck. And if the strength is going to be more in the head, obviously less in the neck, so the difference is more in the head and the neck. And that also shows that the displacement of the inferior screw without any displacement of the superior lag screw, it is more significant. There is more displacement. That also has shown with this factor. So more the difference of that strength between the head and neck, the more the displacement. So can we minimize that? Can we prevent it? Or can we sort this out? How can we do all this? Can we do anything about that? So the single screw system was based on that, which has been going on for many years with the gamma, the TFNA, the AFN, all those sort of things, I mean, the PFNs. The use of the intramedullary comprising a single screw interlocking has it reduced it. But the problem with the single screw, as you know, is a rotational problem, and there is a varus collapse. Now, that also can happen, and that's why the double screw came in. But of course, with the newer ones of the PFN A, all these systems have come, A2, all these things, you know about the amount of the coring of the bone and those things. But let's show you some example. One of the examples that I can show you.